Well, we're back. I got interrupted by a phone call and I couldn't get the thing to pause for me properly, so I just shut it down and saved it. Alright, so we have two more things here having to do with ADH, which Vander calls vasopressin. You could have what's called nephrogenic diabetes insipidus, meaning either you have a problem making ADH, you have a problem making the receptor, or you have a problem making the aquaporins. If you are unable to respond to ADH, then you lose fluid in the urine and you'll be incredibly thirsty. So diabetes insipidus. You also kind of have a situation where you make too much ADH. So sometimes people get a tumor and they make too much ADH, or they have too much of a sensitivity, too much receptor activity. Then they're saving too much water, they dilute their tissues, they have hyponatremia, inappropriately elevated urine osmolality, and muscle weakness, possibility of seizure activity because of the hyponatremia. Alrighty. So there are three ways to divide renal failure. You can talk about pre-renal. That is the input to the kidney. So that's either hypovolemia or hypotension. You don't have enough perfusion of the kidney and cells in the kidney die because they are not being perfused adequately. You could have intrarenal failure, so exposure to toxic drugs, exposure to heavy metals in the workplace, exposure to an inflammatory response or inappropriate antibodies inside the kidney. So the disease process is in the kidney. Or you can have post-renal, so something is blocking the outflow of the urine, and you get a backup pressure and an elevated Bowman's capsule hydrostatic pressure that influences filtration. So say there's a tumor that's blocking the outflow from the kidney. That could cause a post-renal failure. Another way we can divide renal failure is an acute versus chronic. So I'm going to start with acute. Acute means the progression is pretty fast. Are there situations where people have renal failure overnight? Yes, that does happen on occasion. But we usually think about a progression over days or weeks as opposed to over years. Often it's from hypoperfusion, but there are certainly cases where somebody was exposed to some kind of toxin in the workplace and it just destroys their kidneys. Those things do happen. Though the cases that occur from hypoperfusion, not enough blood flow. So you don't get blood flow to the cells of the kidney. They don't have enough oxygen to make ATP. They run out of ATP. So sodium builds up in the cells and the cells swell. Potassium builds outside the cell and you affect the potential and the reabsorption capabilities. So you could have some cells die. Acute tubular necrosis. Now, hopefully, the basement membrane of the tubules would still be there. If the basement membrane is still there, then stem cells can divide, replace the epithelial cells, and rebuild the tubule. This also is something that can happen with kidney transplants. You get a kidney from a cadaver, and there's been some acute tubular necrosis, and the person has to be supported on dialysis while the kidneys heal. So what would you expect to see in some kind of person? They'd have a very low urine output, very low urine flow, a low creatinine clearance. Plasma creatinine would increase. This is something that folks practicing in the anesthesia field are worried about with acute renal failure. So you have a person with a dysrhythmia, or the failure could contribute to a dysrhythmia. You have uncontrolled bleeding, and then therefore the kidneys are perfused. You have infection and vasodilation all over the place, and that can cause the kidneys to fail, and this is associated with a very high mortality rate. So a very, very important thing that nurse anesthetists do is maintain blood pressure, so we have perfusion of the brain, perfusion of the kidneys, and a person who comes out of a surgery helped by the surgery and not harmed. It's very important to take a good history and find out what's going on with your patient. Does your patient already have renal disease? Do they have liver disease? Liver disease can impact the kidney. Do they have an infection and sepsis? Are they quite elderly? Do they have heart failure? So you have people with lots of comorbidities, then you're extra worried about post-operative acute renal failure because of a hypoperfusion problem. Now with chronic kidney disease, of course, there's a history, and the anesthetist is sitting down with a patient before surgery to say, "Hi, I'm a nurse who's going to perform your anesthesia, and we need to talk about some things here." And so you'd find out if this person had kidney disease. It's important to realize if you have a patient that has diabetes or has lupus or polycystic kidney disease or sickle cell anemia or some kind of thing, some kind of disease that they've been living with, you have to realize that that disease has been damaging their kidney very slowly over the years, been damaging their kidney. So if you have a patient with a chronic condition, they probably have kidneys that are in worse shape than you think they are, because they're still perhaps maintaining homeostasis. Remember, your GFR could get down to 60 before you start showing problems. So, and what else might be going on with this patient with this chronic disease that they've had for many years? They could have hypertension. They could have nitrogen in their blood, so urea or azotemia is just nitrogen in general. Maybe they have anemia. Maybe they are not able to get through the night without getting up to urinate. Now, this seems like a lot of older people. And what's that about? Well, if you're in early signs of kidney damage, remember, you're dumping sodium, you're unable to concentrate the urine, so there's actually quite a bit of urination. So this would be in early signs, and you might not necessarily immediately think kidney function, but you should have it in the back of your mind. Now, why are they doing such a good job maintaining homeostasis? Because there's a process that occurs called masking. In other words, as some nephrons die, other nephrons will hypertrophy and work harder. So the kidney as a whole is still maintaining the workload, but it's doing it with fewer nephrons. And so once you realize there's a kidney process going on, it's very, very important to preserve the kidney function that is there so that things don't get worse. There are all kinds of complications you can have because of chronic kidney dysfunction. So people will retain fluid. They will have hypertension. They will lose sodium in the urine. They will retain potassium. They will have low calcium because of low calcitriol. Now, they may continue to pull calcium out of the bones and maintain their calcium, or they will have low calcium. Having low calcium makes you a bleeder because calcium is one of the clotting factors. They could have high phosphate. Remember, calcium and phosphate have a reciprocal relationship in the kidney, and if you're not able to reabsorb calcium, then you're not getting rid of a different P word. Phosphate, there it is. Acidosis, because your kidneys get rid of acid, then that acid is being retained. Anemia, your kidneys produce erythropoietin. If your kidneys are impaired from producing erythropoietin, that leads to anemia. Buildup of nitrogenous waste, so that's that uremia business that interferes with your GI function. You have changes in motility. Neuropathies, tingling and weird sensations, causes insulin resistance and worsens diabetes. And of course, this is a chicken and the egg thing. Did you have diabetes and that damaged your kidneys, and then your kidney damage makes your diabetes worse? This is the same thing with hypertension. Did hypertension damage your kidneys, and now that your kidneys are damaged, that's making your hypertension worse? These things sort of feed pathologically off of each other. There are all kinds of things that can lead to chronic kidney conditions. I've mentioned a couple of them. So lupus is a systemic autoimmune disease, and you have materials getting caught in the filtering membrane and causing damage. Hypertension damages the kidneys. Glomerulonephritis, which is basically a general term to talk about cortical inflammation, can change your kidney function. Polycystic kidney disease. This is a genetic disease, so if you have two alleles, you do not survive childbirth. But if you have one allele, then you have these cysts that form in the kidneys that damage your kidney function. Eventually, you're going to need a transplant. Exposure to things in the workplace. Heavy metal exposure. Exposures of things in the kidney that cause inflammation and a general nephritis. Sickle cell anemia, malformed red blood cells can damage the kidney. Multiple myeloma. So this is basically bone marrow cancer. You produce abnormal antibodies that clog up the nephrons and cause kidney failure. Amyloidosis, so the amyloid proteins that build up in the brain for Alzheimer's disease. This process can happen in peripheral tissues, can happen in the liver, it can happen in the kidney. And of course, diabetes is a very important risk factor for renal disease. So let's do some compare and contrast. You know how much I love to do this. What happens if you have a pre-renal disease versus an intrarenal disease, and how is your patient going to look different? Well, pre-renal disease is because you have hypoperfusion. So you have a patient with low blood pressure, with low blood volume. And because the kidneys are not being perfused, your afferent arteriole is not going to get stretched. You're going to make all the renin that you can. That renin is going to set off the renin-angiotensin system, and aldosterone and angiotensin II are going to try to save every little bit of sodium it can and every little bit of water it can. So this person, at first, the kidneys are not broken. It's the input to the kidneys that's the problem. And so the person will save all the sodium and water they can, and they will make a very, very concentrated urine. And of course, this person needs fluids. Now, what if the damage is happening in the kidney? That's nephron damage directly. So the kidneys are the thing that's broken, and so the kidneys cannot compensate. This person is going to make a dilute urine because they're losing sodium and they cannot concentrate the urine. So giving fluids to this person is actually not helpful. That's just going to make a bad problem worse. So this person needs you need to figure out what the primary issue is, and this person needs dialysis support and that sort of thing. You know, and so this person maybe is a cancer patient and they're getting chemotherapy, and the chemotherapy agent is getting concentrated in the kidney and then causing an intrarenal problem, or maybe they're having a bad reaction to a blood transfusion. Um, you know, they've got a terrible pain condition and they're using a lot of pain medicine that then's getting concentrated in the urine and causing nephrotoxic kinds of things. So something that you will need for your boards and something that's nice to know is that nephritic versus nephrotic syndrome. And so notice I have a little memory aid. Nephritic is inflaming. Nephritis is inflammation of the nephrons. Nephrotic syndrome is literally holes in the glomeruli and protein is being lost. So there'll be albumin in the urine and less albumin in the plasma. So nephritic is inflaming, whereas nephrotic is oncotic. And one can progress to the other. So I'll just finish up with a few more thoughts about anesthesia. This nephrotic syndrome, we just brought up albumin. Albumin has an impact on so many aspects of physiology. It's important for oncotic pressure. It's important for maintaining blood pressure. So if you have a patient with hypoalbuminemia, you're doing all kinds of extra stuff to help that person maintain blood pressure during the surgery. Remember, all kinds of hormones hitch a ride on albumin. This is going to affect the kinetics of a hormone and the kinetics of a drug. Drugs bind to albumin. If there's less bound and more free, that affects the drug clearance. People with kidney failure have acidosis. Acidosis then has a huge image. I'm wondering if that is supposed to say impact. That's kind of goofy. Huge impact on drug binding and effectiveness. Hydrogen ion is really reactive. It binds to all kinds of things, and those things are proteins. And when hydrogen ions bind to proteins, you affect the charge distribution, you affect the shape of the protein, and you affect the binding characteristics of a receptor or the activity of an enzyme. If your patient has kidney failure, you might choose a different drug, a drug that's cleared by the liver, and a nice example of that would be propofol. If people have reduced clearance, they need reduced drug doses. And when you have a patient with a lot of comorbidities, they have a lot of drugs. And the drugs they take will interact with your anesthetic agents. So, for example, beta blockers are notorious for interacting with things. I just give you this list to think about how the kidney impacts your practice and to help the students who are not nurse anesthetists to see appreciate all the balls that are being juggled by a nurse anesthetist and all the ways that kidney function can impact clinical function. Do I have a question slide? No, I do not. So I will end it here, and I'll see you in class. Take care, everybody.